Good evening, everyone, and welcome to tonight's event on cancer management in general practice. I'd just like to start by welcoming and thanking you all for joining us tonight and acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay my respects to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. My name is Rebecca, and alongside my colleague Lauren, who is also online tonight, we are the Cancer Management Project Officers at CESPN and look after the GPCanShare Cancer Management Project, which will be discussed later tonight. Please note that this webinar will be recorded and available on the CESPN YouTube channel within the next couple of days. At the end of the session, the evaluation survey will pop up on your browser. Please take the time to fill this out and provide feedback on the education and webinar experience so that we can continue to improve the CPD on offer. And also we'd like to issue some certificates of attendance if the survey is completed. Please submit any questions using the Q&A box located in the bottom of your screen throughout the presentation. To view this box, just hover over the toolbar at the bottom of your screen and you'll see the Q&A box. I'd like to introduce our first speaker tonight. Dr. Carole Harris is a staff specialist at St. George and Sutherland Hospitals. Dr. Harris is an experienced oncologist with a special interest in breast cancer, but also kidney, prostate, bladder and testicular cancer. Dr. Harris runs the oncology teaching program at St. George and Sutherland clinical schools and actively engages with ongoing education for up-and-coming physicians. Dr. Harris will talk about the management of breast cancer, including ongoing survivorship care. Thank you, Dr. Harris.
Hi, everyone. I'm just going to share my screen, use my IT ability. Hopefully that worked. So as mentioned, my name is Carole Harris. I'm an oncologist with an interest in breast cancer and GU cancers at St. George and Sutherland Hospitals. And I'm also have helped establish the survivorship clinic at St. George Public Hospital, which I'm going to briefly touch on at the end. Okay. What I'm going to talk about today is just a little bit about cancer and breast cancer and where we're going with it. I think it's important to have a quick understanding of breast cancer treatments and toxicities, because otherwise you don't know how to manage them in general practice, and follow up, particularly focusing on preventing recurrence and managing these toxicity, and then a bit more on survivorship. Australian Institute of Health and Welfare put out a report last year that talked about cancer survival rates in general. And the good news is cancer survival rates continue to improve while death and incident rates are falling. They expect quite a large number of, I'm just going to move that up my screen. They expect quite a large number of cancer diagnoses by the end of 2021. And as you can see, over the last, say, 25, 30 years, there's definitely been improvement in survival. Now, it made me partly giggle when I saw that they said the impact of the COVID-19 pandemic's not known. I think this report was written last year, and I can tell you it certainly impacted cancer services, and we've certainly seen delayed diagnoses without question, but I think that's not going to bear out till a few years' time in these sorts of reports. But you probably all know breast cancer is common. There's a 1 in 8 lifetime risk. And when you look at survival, 5-year survival across all stages, so early and late, is about 91%. Obviously, the more advanced diagnosis at progression, the poorer the potential survival. But if you quickly do your maths, going to common cancer, the commonest cancer in women, and most women are living a long time, we've got a lot of patients surviving for a lot longer. And you will all see them, I'm sure, in your clinics or in your practices. And we've got a balance here because there's not enough room for these patients to go in all the follow-up clinics everywhere or in all the GP practices. Diagnosis of breast cancer can be either on symptoms or screening. You probably know what the different breast cancer can look like, but on the whole, patients who are picked up on screening, which is a mammography from the age of 50 every 2 years, they're normally earlier cancers, and they normally tend to be slower growing. And some argue that perhaps some of these cancers, if left alone, may not have caused any harm for people. But I think it's always a good idea to find something early and treat it. Those that are developed that we find on symptoms are often more aggressive cancers, and of course there's exceptions to all these rules. So mammography is from the age of 50 to 74, although you can get screening from the age of 40 if considered high risk. Just a comment about breast cancer itself to understand. So if you like, there's 4 main types of breast cancer, or really 3. The luminal A and luminal B are basically better behaved cancers, and these are your hormone positive breast cancers. The stronger the estrogen, and ideally the stronger the progesterone, the nicer the cancer is. The HER2 positive breast cancers are those that have a receptor expressed on the breast cancer cell that is HER2 positive, whether or not the estrogen and progesterone are positive. And the triple negative means quite literally these 3 receptors are negative. So you've got your nicer hormone positive to your HER2 to your triple negative breast cancer. And partly why this matters is prognosis and prognostication, but also the types of treatment that we can give. The hormone blocking or endocrine therapy in the hormone positive, HER2 blocking in the HER2 positive. And the triple negative breast cancers, on the whole, we've been mainly stuck with using chemotherapy. Of course, in some of the nastier other breast cancers, we also may need to use chemotherapy. Treatment's traditionally been surgery, then chemotherapy if needed, radiation if needed, and then endocrine therapy. But it's all kind of changing in the last few years. Even since I've been an oncologist, it's all sort of turning on its head again. With each step, we have particular toxicities and side effects that we have to deal with. Everything from the lymphedema with surgery, the well-known probably chemotherapy side effects, the radiation, which is often fatigue and skin changes, but potential damage to the underlying tissues. And then the endocrine therapy, and when this is the area where most breast cancers are hormone receptor positive, and this is where even in my follow-up clinics, I probably spend the most amount of my time dealing with the issues of endocrine therapy. So I'm going to spend a little bit of time on that today. Quickly on hormone positive breast cancer, we're now adding in extra things like zoledronic acid, or Zometa, if you know that, to reduce risk of bone metastases. We're giving people more endocrine therapy, and we're inducing menopause to improve survival. And there's a new drug which may or may not be beneficial called abemaciclib, which is coming, shall we say. The HER2 positive breast cancers, we're kind of switching it around. So these are more aggressive cancers. We're tending to use chemotherapy up front, and then doing surgery, and then we use radiation and endocrine therapy as needed. But there's also new HER2 therapy. So if you see a patient and they're on one of these weird things, basically all the side effects of the HER2 therapies are more or less the same, but there's just newer ones that have been shown to be more effective. And it all sort of depends on a patient's response to upfront chemotherapy in HER2, for example, whether we'd use the medication called TDM1. So it's complicated. The same with triple negatives. We're now giving chemotherapy up front to really, get control of the cancer before offering surgery. And recently, only earlier this year, there was the first data that really definitively showed that immunotherapy might be useful in this space. And immunotherapy comes with its own set of problems and toxicities. As well, if people have chemotherapy and they also don't have a complete response, we're offering people oral chemotherapy. So again, there's more and more treatments. I would say the treatment of hormone positive breast cancer is really just now hormones. There's less and less chemo that we're giving, but more and more of these extra therapies in the triple negative and HER2 positive breast cancer space. Now, I went to Cancer Australia and see what the official guidelines are with follow-up for breast cancer, and they gave this whole list of many things that you could or couldn't do. But I think, keeping it simple, there's 2 main things I do in my clinic, and that's I want to check for local or distant recurrence, and I want to manage the toxicities as best I can. And I'm sure, just like you've only got a set time to do this. So perhaps trying to give you some signposts of how to make this a bit easier if you see these patients in your clinic, or you get letters back from the oncologist or talking to the oncologist about what we're actually doing. Checking or preventing recurrence. The schedule recommended not only by Cancer Australia, but international guidelines as well, is not completely straightforward. And essentially what it is seeing a patient regularly and doing a history and examination. So this is more frequent in the earlier years, becoming less frequent in the later years. A mammogram and ultrasound once every 12 months is indicated. And here's the bit that patients struggle with, sometimes oncologists struggle with, is it's not recommended to do routine blood tests or scans. And I think the official wording on some of the guidelines is unless clinically indicated. And that's hard because patients know people who are having treatment for lung cancer or melanoma, and they're getting PET scans every 3 months, and they come in wanting their scans. But certainly the evidence has shown that doing an investigation when someone has a symptom versus just doing them routinely, the outcomes are no different. So what we do is if someone has a symptom, I'm very happy to investigate, but I try not to do all the scans unnecessarily. And I often do discuss, have you got a good GP? Are they doing, especially on some of the older patients, are they doing annual reviews and blood tests? And just get them to send a copy to me rather than to do a whole set of blood tests which aren't really clinically indicated. I do say that, though, that there are some patients who are very, very hyper anxious, and I've found that negotiating, say, a scan once a year because the clinical indication is their anxiety. I'm not sure if that's a bit naughty, but that sort of seems to work as well. One thing I do though, is I try and educate the patient when I'm seeing them. And I actually literally often do this as I'm examining them. Breast cancer, if it comes back, can come back locally, and that's what the mammogram and ultrasound is looking for. But the commonest other places of recurrence are liver, lung, and bones. And in the HER2, potentially down the track, the brain as well. So I educate people about, for the liver, I explain where the liver is. You might get some pain here. You might go yellow. You might have some abnormal blood tests. So I don't push that one because then they want blood tests. With the lungs, I talk about how people can get shortness of breath or cough, but it's persistent. Anything that comes and goes isn't cancer, but things that persist and get worse. And it's the same thing before a diagnosis of cancer. When you seek medical attention, you do the same thing. But this time, I guess we're looking to see if there's any untoward cause, such as a malignancy. And in bones, it's not the aches and pains. It's a single sort of, I've got a pain here, if you like, or in one area that they can point to that's keeps them awake at night, that's persistent and strong. It's not that sort of, I get up, I move around, I shake my hands and it goes. So it's not like that. And I find if I do that while I'm examining them, that's been quite a helpful tool for me. Talking about risk factors, and I'm going to briefly do this because I think Kerry is going to do this in more detail, but there's the risk factors that we can't change. Being a woman, getting older, our family history, our genes, our menopause and menarche history, and our breast density. And the breast density is quite an interesting new sort of, I think, awareness that there is talk about trying to incorporate breast density measurements more and more into when we do see mammography or even MRIs. And there's quite a push from the radiologists to try and make MRIs a little bit more standard in follow-up. There are risk factors that we can change, and I think it's a responsibility of all of us as doctors to have a conversation with this. So it's being physically active, maintaining a healthy body weight, reducing alcohol, where possible breastfeeding, although often when you're having a conversation with breast cancer patients, we've missed the boat there, and quitting smoking. Now, I went to find a study about exercise and breast cancer, and there are lots of them. And again, I think Dr. Uebel is going to go into this in more detail, but basically there's all sorts of exercise studies in breast cancer. Some are prospective, some are retrospective, some use different measurements, but all of them reduce the risk of breast cancer recurrence in patients. And it's really quite startling. And I think that's the take-home message. And I said, I think Dr. Uebel's going to go into more detail, but exercise, if we can tell our patients to exercise, it's so important. I was involved in a study recently where a simple intervention from a doctor helped basically people change practice. And it's really interesting. We always bang on about people should be on endocrine therapy, and it's really important to go from 5 years to 10 years. But that extra 5 years gives you about an extra 5% benefit in reducing breast cancer recurrence. And yet you're getting this great benefit if people can exercise. So with that in mind, which exercise and how much? And I'll just briefly introduce you, if you don't know, about the COSA position statement on exercise in cancer, which recommends 100 minutes of moderate intensity or 75 minutes of vigorous exercise, plus 2 to 3 strength exercise sessions a week. And I think if we can all encourage our patients, and as GPs, if you've got the healthcare plans that you can link into, you're in a winning situation from us as a specialist. And the role of the doctor basically is also to remind patients or bring this up with patients. I think it's really important. The next thing, ET stands for, endocrine therapy. It's a really, really simple concept. If you want to keep your patients alive longer and living well, you got to ask them if they're taking their medication. And after I went to a conference where this was discussed, I went home and to my next clinic, I asked patients if they're actually taking their hormone treatment that they're supposed to be on. And it was quite startling, the number of people that went, oh no, actually I stopped it last year or something like that, which is really quite disconcerting. And this shows that basically in the first year, you've got fewer people that stop. But, you know, between 3 and 4 years down the track, AI stands for aromatase inhibitor, you've got 40 to 50% of people who basically are just not adherent to their endocrine therapy. And that's certainly going to affect the risk of recurrence. So asking patients if they're taking their treatment is really important. Well, not obviously, but it stands to reason that if you're not taking the medication for breast cancer, your survival outcomes are not as good. And one of the reasons for non-adherence is the symptomatology. So these medications can be quite toxic, and I'm going to go into a little bit more detail shortly about the different therapies. But if you're getting bony aches and pains and you're getting hot flushes and you're feeling unwell, you're probably less likely to want to take your treatment. We do employ different strategies in the clinic where we will sometimes switch therapies. I also do switch brands of treatment, which intuitively shouldn't work, but it does. And I switch terms of days that people take treatment. There's also some evidence that giving people a drug holiday, say for 6 weeks to 3 months, or 6 to 8 weeks is normally what I do, then they might have a better compliance or a better tolerability afterwards. Moving on to managing toxicities. So normally in the clinic, you're not so much worried about the chemotherapy. I'm not going into this because I'm talking about survivorship long term. So when patients are on chemotherapy, we're seeing them in clinic each cycle of treatment. But just a couple of points. The chemotherapy, the 2 main types we use is anthracyclines and taxanes. And the HER2 treatments, as I've talked about, only about 15 to 20% of breast cancers are HER2 positive, but we use these HER2 therapies. And we know that they can cause cardiac problems. There's been quite a lot of research and there's a lot of interest on this topic at the moment about the cardiac effects of people having poor cardiac outcomes with breast cancer, and it's multiple reasons. It could be that have had these treatments, the anthracyclines or the HER2 therapies, and normally this shouldn't occur down the track, but it does. And when you think about it, in a lot of these patients, we're making them postmenopausal, so we're taking away that protective effect of estrogen. And also whether there's a direct other relationship, we're not quite sure, but there is certainly an increased risk of cardiac complications for patients who've been diagnosed with breast cancer. So for both ourselves, and I'm going to be honest, I know GPs are much better at looking at risk factors, being aware and monitoring for risk factors of cardiac disease is really important. The taxanes cause peripheral neuropathy. It's supposed to be reversible. I've had so many patients in my clinic where they've still got ongoing peripheral neuropathy down the track. The first thing is time. It should improve with time. It should. It doesn't in everyone, unfortunately. There's been some studies that show that exercise, once again, improves peripheral neuropathy. And we link people into exercise programs, or we've got a study on that as well. And we can use neuropathic medications if we need to, but I try and certainly do the other two first. Just to go through hormone blocking treatments, there's two main types. There's tamoxifen, and then there's the others, the aromatase inhibitors. And I don't know how you know if these work, but tamoxifen is a selective estrogen receptor modulator. Can be used at any age because whatever estrogen you've got in the body, it blocks it basically joining with cancer cells, and has some rarer side effects of a uterine malignancy and blood clots, as well as the classic menopause symptoms. But everyone Googles tamoxifen and thinks it's the scary one. But I would say the aromatase inhibitors are probably harder to take. We know that on the whole, the evidence is that the aromatase inhibitors are preferred and superior where possible to tamoxifen. And it makes sense really, because aromatase inhibitors, funnily enough, block aromatase. And aromatase is basically the mechanism whereby estrogen is made in the peripheries when you're already postmenopausal. So normally you're postmenopausal, you make a little bit of estrogen, but with the aromatase inhibitors, that little bit of estrogen is blocked. And so you have all the symptoms of menopause, plus you no longer have your heart and your bones protected. There's a very good paper in the Lancet. I've realized I haven't referenced it, my apologies, but looking at all the toxicities of these estrogen or aromatase inhibitors particularly, but endocrine therapy, hot flushes, fatigue, musculoskeletal symptoms, sexual dysfunction, and weight gain. And really, the darker the colour is where there's more sort of level 1 or 2 evidence to say that these interventions work. For hot flushes, we've got a number of medications that we use, as well as cognitive behaviour therapy. For fatigue, once again, cognitive behavioural therapy and exercise. With musculoskeletal, there's some medication. It's musculoskeletal meaning the arthralgias that I'm talking about. Again, some medication and exercise. And I find the sexual dysfunction really quite hard to have an easy fix for. Although hormone, vaginal moisturizers, lubricants, and cognitive behavioral therapy do help. And on this slide, it sort of goes into a little bit more detail. The more ticks, the more evidence. And some of these, I think we're better at managing. I do find the sexual dysfunction sometimes not talked about enough, and therefore perhaps under-treated, shall we say, or under-addressed is probably a better way of putting it. Just a comment, what this is showing, this is more in metastatic breast cancer, but there was a study in metastatic breast cancer where they talked about patient-reported outcomes. So asking the patient what their symptoms was. Surprise, surprise, when the doctor assessed the patient's symptoms and the patient assessed the patient's symptoms, the patients had far higher than the doctor. And in one study, they basically got patients to fill in for paperwork just to report the patient-reported outcomes. So I feel tired, I've got hot flushes, all those sorts of things. And they found that that actually improved survival, actually asking patients for their symptoms and how they were doing. There's an Adelaide group which are doing an app or a web-based program called findingmywayadvanced.org.au, where they're trying to incorporate management for metastatic breast cancer patients. Slightly outside, but it was the best demonstration about asking patients about their symptoms. Just briefly, we mentioned bone health as well. So if you're on an aromatase inhibitor, you need a bone mineral density every 1 to 2 years. If you've got dodgy bones, I do it yearly. If you've got better bones, I do it 2 yearly. We can't forget mental health. There is a lot of, obviously, issues with the diagnosis of breast cancer and patients' new normal or re-establishing themselves, intimacy issues, relationship issues, fear of survivor guilt, all sorts of things. And psychologists are helpful, plus just talking to the patients. I always find the diet question really hard. There's no specific type I recommend. There has been some suggestion that low-fat diets might be helpful, but it's the sort of thing that changes with some degree of regularity, where the greatest evidence is. We know to keep patients at a healthy weight range. And I'll just comment on the gut microbiome, because this is really a fascinating area of research at the moment. And if we change the gut microbiome, it has some interaction perhaps with cancer diagnosis and risk of cancer and risk of recurrence. What changes all the gut microbiome is all that stuff we know about good diet, exercise, no alcohol, or minimal alcohol, no smoking. So it might be explain the symptoms perhaps more than anything, or explain the risk factors, I should say. Just a comment, we've set up the Survivorship Clinic at St George Public Hospital, which is run fortnightly, and it's for anyone with a curative breast cancer is one of them, but a curative cancer 3 months since completing their acute treatment. Unlike some centres which have lots of money, we're doing this all sort of on top of our day job, so to speak. So at the moment, it's a one-off visit, and we try and direct patients into pathways to improve their care. But, you know, the great hope is one day we'd have an entire wellness centre, and we can look at people from early to late cancer and looking at all these ways of improving their outcomes. I'm aware of time, so very, very briefly, I think later on in this session, someone will be talking about GP shared care. There are a couple of studies within that you might be asked if you'd like to be involved in, including the triage tool or the INCA study. We're running or involved in some what's called in-focus studies looking at exercise for patients with peripheral neuropathy from chemotherapy. The government's about to announce, if they haven't already, quite a lot of funding for menopause in New South Wales, which is going to be exciting, and we're hoping there'll be some publicly available clinics for patients. And like I talked about that app, there's lots of talk about trying to do apps to try and improve people's follow-up experience, help them manage symptoms, and there's various ones sort of in development. But very quickly, given time, I guess some of my approaches or how I do it when I'm following up patients, I educate people to try and prevent the recurrence. I often get when people have had their mammogram ultrasound, I say, go and feel your breasts now, know what they're like, because if you've had a normal one and you know what's normal for you, then that's really helpful. Obviously, they do need their mammogram, and normally we do an ultrasound as well. Do try to discourage regular scans and bloods, but I get my arm twisted like everyone else. For toxicities, ask about compliance, do the bone mineral density, look for heart disease, risk factors, exercise. Managing menopause, I find not a simple solution, but we're working on it. And I guess use a team of experts. So in hospital, sometimes I'm lucky that I have the dietitian and the psychologist I can use. But using all our allied health is really important. So I'm just going to pause there because I think I'm almost out of time. I'll put my email address, and that is the most useless or unhelpful long email address for the Survivorship Clinic for some reason. But you can email the Survivorship Clinic directly if you need a patient referred. And I'm happy to take questions as well. I think I'll stop screen sharing.
Thank you, Dr. Harris, for that very comprehensive overview on breast cancer. Does anyone have any questions for Dr. Harris at this stage? Can I ask a quick question about eligibility for the Survivorship Clinic? So does a person have to have be in survivorship for a certain amount of time or post-treatment?
You just have to have completed your early treatment. So in breast cancer, that's normally chemotherapy or radiation therapy. You can still be on hormone treatment. You can still be on the HER2 treatment because that goes for up to a year. But as long as you finish your chemotherapy and radiation, we don't see people immediately because often some of those really acute issues, they improve with time. So the, you know, I say I use hair loss as a barometer. So once people's hair is starting to come back, if they've had chemotherapy, you'll find that their some of their peripheral neuropathy is going away and their fatigue's improving and those sorts of things. So as long as they're 3 months post-acute treatment, we're happy to see them.
Okay, thank you. There's a question in the Q&A box. Can I prescribe vaginal estrogen creams or Passaries? Sorry for my mispronunciation. That
is the, I think, hardest question in the management of follow-up for hormone-positive breast cancer. And it is not an easy one to answer. So you'll meet, I was in a breast cancer meeting actually it was pre-COVID, so it was 3 years ago, and they asked this question to the room, and literally the room was divided in 50-50. Half said that they would give it to their patients, and half said that absolutely no, they wouldn't. If someone's on tamoxifen, oh no, let's take it back. The studies have shown that a small little amount of estrogen is absorbed when somebody has vaginal treatment. So as a first step, I try and do the simple things first. So I try and do vaginal moisturizers, I try and do lubricants, I try and get a psychologist to see them, but no, it doesn't always work. I then do talk to them about estrogen. I do, some of my colleagues won't. Estrogen, in the studies, a small amount was absorbed, but there's no evidence to show that that small amount absorbed actually increases your risk of breast cancer. And it was only tiny. If you look at even pregnancy, you would think becoming pregnant would increase your risk of a secondary breast cancer, but actually it doesn't. So we don't know. So what I do is I have a honest conversation with patients, and I go through, look, there's a theoretical risk that a bit could be absorbed. How do you feel about that? I've had patients who've said that their intimacy issues or vaginal dryness, whatever, far outweigh any risk of, they're so important that they will do it. And I've had other patients go, I don't want it, when I even have this conversation. When you're on tamoxifen, it is easier, because if you think about it, tamoxifen blocks estrogen in the body. So we give tamoxifen to 20-year-olds, well, no, hopefully we don't give it to many 20-year-olds, 30-year-olds who've got breast cancer, who are still having periods and still having high levels of estrogen. And as I said, it's a receptor blocker, so it still allows estrogen production. Very easy in those people, but they're probably the people who don't need it. So the official line is you need to have an informed consent discussion, and I do that not uncommonly with patients, and some do and some don't. But you'll find some oncologists who point blankly say no, but that's not me. That's a really good question. Shut up now.
Thank you for that response. There's just one last question in regards to the survivorship clinic.
Yeah.
The question is how to refer into the survivorship clinic, and also can practice nurses refer directly?
So the practice nurse question, I think, because it's technically it's a referral to a medical clinic, I think we need a provider number. So I'm sorry, I'm not quite sure how that works with practice nurses in GP clinics. So I think you would need probably you do need a provider number to refer in. You can do it one of a couple of ways. There is that email address, and if there's a way that can be sent out or forwarded, I know there was some discussion of forwarding something, then it's on the end of my presentation, or I can send it to Jeremy, so I can make that available. Otherwise, honestly, you could just send it through to St George, fax it or email it to St George Cancer Centre to Survivorship Clinic. You can use it to my name and it will find the right place.
Okay, great. Thank you so much, Dr. Harris. That we can have that email up and sent to participants with the survey. No problems with that, so thank you. Our next presentation tonight will be a brief overview on the GPCanShare program from Jeremy Chow, who is an Integrated Care Coordinator for the GPCanShare program based at St George and Sutherland Hospital. He'll be talking about the program and also the phone line. Thank you, Jeremy.
Good evening, everyone. My name's Jeremy. I'm one of the nurses working at St George and Sutherland Hospital. So I'll give you a quick overview of the GPCanShare hotline. GPCanShare hotline is run by specialist nurses provide any cancer care related clinical advice, navigation to any of the GPCanShare coordinators. The hotline is actually for all health professionals like yourself, and it covers the surrounding areas between the main hospitals, for example, Prince of Wales, St George, Sutherland, RPA, and Concord. Currently, we are doing some GPCanShare care plans, as you may have seen, and we're currently expanding on from breast cancer to colorectal and some other diseases. So if you have any further questions, feel free to contact myself to the emails below, and happy for any questions.
Hi, Jeremy. There just seems to be a little problem with your audio. Would you be able just to speak and I'll be able to hear if you're...
Hello, can you hear me?
Yep, that's better. Yeah, thank you.
So do you want me to repeat that again? Sorry, Rebecca.
Yeah, maybe just from the phone line, just that brief overview. Sorry, the audio was cutting in and out.
That's okay. So the GPCanShare hotline is run by specialist nurses to provide any cancer care related clinical advice to both patients and also for both patients and health professionals like yourselves. The hotline is run by special nurses that covers most of the main hospital areas, including Prince of Wales, St Vincent, St George, Sutherland, RPA. And it provides clinical advice if needed for any of your health professionals. The contact details are as per indicated below, and feel free to contact us if you have any questions or queries, and happy to answer your questions if there is.
Great. Thank you, Jeremy. I really appreciate that overview of both services. If anyone would like further information on GPCanShare and the phone line or the phone line, you can find that information on the cancer management webpage of the CESPN website. Also, we've included an opportunity for you to provide a contact email, and we can send some further information out. That submission will be on the evaluation survey. Our next presentation is by Dr. Kerry Uebel. Dr. Uebel is not only a clinician, but also an academic GP who resides at the University of New South Wales as a senior lecturer in public health and community medicine. Dr. Uebel has spent over 30 years in South Africa looking at the provision of care to HIV and TB patients. Dr. Uebel has reported on numerous journal articles, and today she will discuss the benefits of team care arrangements within cancer management. Thank you, Dr. Uebel.
Thanks very much, Rebecca. Let's see if I managed to share my screen as well as Carole managed to share hers. Can everybody see that? I hope so.
Yes, that's perfect. And your audio is great. Thank you.
Right. Yes. So as Rebecca mentioned, I'm a senior lecturer in the School of Population Health at the Faculty of Medicine and Health. I've come to that via a very circuitous path. I spent most of my I graduated in Sydney many years ago, but I spent most of my clinical life in primary care in South Africa, where the commonest diseases are HIV and TB, very different from primary care in Australia. I returned to Australia 4 years ago, and I've since been working as an academic GP, and I work just 1 day a week in a bulk billing practice in Campsie. So you know where I come from. I have not spent a lot of time in general practice in Australia, so I think many of our participants would have a much broader view of general practice, but I want to speak briefly about GP's lifestyle advice and management of cancer. Now I've got to work out how to progress my slides now. That's always fun. All right, look, I'm going to be presenting a fairly simple talk this evening, and the way I thought that I would do it is to talk about, as GPs, what we know and what we don't know. Let's see if we can get this thing to progress. Right, so in general practice, we know about preventive care. We know about whole patient care. We know about family care. We know about continuity of care over time. We know about care in the community. We know about comprehensive care. We know about team care. There's a lot of things that we do all the time as general practitioners, and these are really valuable things when it comes to the care of cancer survivors. So when we apply what we know about GPs to cancer care, we can provide care to prevent cancers. We can support patients on cancer treatment. We can help patients and their families to navigate and understand cancer treatment. And I was involved in a research project about 2 years ago, interviewing some cancer survivors and GPs and specialists about the concept of shared care for cancer care. And I got a number of stories from both GPs and patients saying, yeah, they did get a lot of advice from the oncologist, but what they did was go and speak to their GP because their GP knew them. And the GP many times comes from their own community and speaks their language. And so GPs can actually help patients and their families to navigate the whole system and be a resource and a backup for many of our patients when they've been diagnosed with cancer, when they're going through the whole treatment system at the cancer centre. And it was really quite striking talking to both patients and GPs about how many of them said, no, but my patients came and asked me, the oncologist has said this, what do you think? The oncologist has told me this, what do you think? And many times it's just a reassuring thing that GPs can do because they come from the same community. But I think as GPs, we can manage many of these cancer treatment side effects. But especially one of the broader things we can do is that we can keep our cancer survivors healthy and well. And the other thing that we can do as GPs involves some of the other important team members that we have seen from what Carole has said are really important to a cancer survivorship. Right. What we do know about healthy lifestyle is that healthy lifestyle can prevent 4 of the big 5 cancers in Australia. So the big 5, as we probably know, melanoma is a big one, lung cancer, prostate cancer in men, breast cancer in women, and colorectal cancer in both. And we know that there are lifestyle factors that predispose to these cancers. We know that smoking is an important factor in lung cancer, but it's also important in colorectal cancer. It's also important in bladder cancer, pancreatic cancer, all of your GIT cancers from the mouth down. So smoking is a big one. We know we've known about this one for a long time. We know that sun exposure is important in our melanomas and other skin cancers. But some of the others, I think our knowledge about those is much more recent. Physical inactivity in and of itself is a risk factor for colorectal cancer. It's a risk factor for developing breast cancer. It's a risk factor for developing endometrial cancer. And of course, another related risk factor, and again, we've got much more information on this fairly recently in the last 10 years or so. Obesity in and of itself, apart from physical inactivity, is a big risk factor for colorectal cancer, breast cancer, endometrial cancer, but also other cancers like hepatocellular liver cancer. Alcohol has been shown to have a separate effect on colorectal cancer as well, breast cancer, liver cancer. And the last one, poor nutrition. Poor nutrition with a high-fat diet, high-processed diet, high-red meat diet has also been shown to be a separate and independent risk factor for colorectal cancer. So we know that a healthy lifestyle can actually prevent 4 of the big 5. Not a lot of evidence about healthy lifestyle and lung cancer, except of course for smoking. Okay, so what we do know is that at GPs, we can prevent cancer by encouraging our patients to quit smoking, to get exercising, to maintaining a healthy weight, to eating a healthy diet, and cutting down on alcohol. Now, we know we do this all the time. This is part of what we do as GPs. We work with patients, we find out about their smoking history, and we talk to them about quitting smoking. We're not doing it intentionally to prevent cancer. We're not doing it, oh, I must go and ask about smoking to prevent cancer. We're doing it as part of our comprehensive care of patients. We're talking to patients about exercising. We're talking to patients about maintaining a healthy weight. We're talking about eating a healthy diet. We talk to our patients about the alcohol. And like I said, we're not doing it just to prevent cancer. We're doing it to keep our patients healthy. But as we're doing this, this is what we're actually doing, in fact. Okay? What we don't know, we don't know how many people will not get cancer, how many people will not get cardiovascular disease or osteoarthritis or COPD. We don't know how many people will not get depressed because we help them all to adopt a healthy lifestyle. Nobody's going to track down how many patients we managed to prevent all of these things, because we're doing it as part of our whole patient care and our comprehensive care in patients all through the ages, from our young people, from our teenagers, up to our older patients. So we are helping patients to adopt a healthy lifestyle. It's about more than preventing cancer. It's about our comprehensive care. But because we're doing this comprehensive care, we're making an impact on preventing cancer. Secondly, if we look at helping patients who are on cancer treatment, this is what we do know. We can help to explain their cancer treatment in terms they can understand. It's quite a bewildering experience for our patients. When they go to the oncology centre, it's very fearful. Their lives have changed dramatically. They get in complicated treatment. They get amazing explanations from the cancer centre, but sometimes they need to come and talk to a doctor they know well from their own community. As GPs, we're a trusted source of information. And we can do this. We can back up the information they're getting from the oncology centre in a setting where they're coming and saying, listen, I just need to come and talk to you. We're often able to do that because we're culturally able to support families and the patients during their cancer treatment, because we often come from the same community. But importantly as well, we've got access to community support and we've got access to team care. And that's one of the things I want to finish on as I talk here, because I think that's something that we need to look at as GPs, is our ability to access team care. These are some of the things that we don't know, and this is where some of the research is going on, and this is where GPCanShare and other programs are trying to look. How can we improve communication between GPs and oncology centres for our patients on active treatment? And that is one of our big gaps, I think. As GPs, we can be diagnosing patients with cancer, referring them to the cancer centre, but there's often this big gap where we're not able to communicate much with the oncology centre, and in turn, the oncology centres don't have time to be able to communicate on an ongoing fashion with GPs. So the GPCanShare program is looking at this communication issue, but more around survivor care. And there's also the trial of a web-based tool to generate a letter to GP, again with survivor care plans. There's a couple of other questions here. How can we have ongoing access to surveillance results for the oncologist and the GP in a shared care program? And we know that there are gaps there when it comes to accessing results, that as GPs, we don't have direct access to be able to go and look at CT scan results or previous monitoring blood results that we would use in patients, for instance, who are being monitored for colorectal cancer. And there's a lot of work that needs to go into how do we improve this communication between GPs and oncologists. And the other question as well is, how can we involve GPs as active members of the treatment team? Because actually the GPs can contribute to the management of the patient during active treatment. The big issue here is, how do we communicate? How do we get involved? I don't have answers to those questions, but those are some of the things that I think we need to be exploring with some of the programs we're doing. How do we improve the communication during active treatment and when they go from active treatment to survivor care? And the third area of care is helping cancer survivors. And what we do know is that at GPs, we can help cancer survivors. Carole's talked about some of the ongoing side effects from treatment of breast cancer with the aromatase inhibitors, with some of the chemotherapy. And I don't know if you picked up the message, but one of the important interventions that can help with things like fatigue, chemo fog, even some of the musculoskeletal problems and mental health is exercise. And exercise is one of the things that we can actually help with. We can help with decreasing the chance of cancer recurrence. you've heard Carole saying one of the key things is to do actual local and general examinations and explain to patients what's going on. We can do that. But a big thing, and again, Carole mentioned this, one of the big risks in people who are cancer survivors is that they have a higher risk of other chronic diseases. And those would include cardiovascular disease and diabetes. And that's easy to see from the risk factors being physical inactivity, obesity, poor diet, smoking. One of the things that actually impacts cancer survivors is the increased risk of cardiovascular disease and diabetes. And again, this is something we do all the time as general practitioners, and this is our specialty. Decreasing the risk of cardiovascular disease and diabetes, managing the risk. So we can help with ongoing side effects. We can help with surveillance. These are the things that Carole was talking about in the Survivor Clinic. But the things that we can help with most in general practice are things like decreasing the risk of cardiovascular disease and diabetes. This is comprehensive care for our cancer survivors. And we can do a lot to improve their mental health. And Carole again has mentioned the psychological effects, the ongoing psychological effects in cancer survivors. And again, there are many interventions that can help here, but one of the big ones that can help is actually physical exercise. So we can do all of these things here simply by supporting healthy lifestyle changes in our patients. And what do we know? What we do know is that cancer survivors who achieve and maintain a healthy lifestyle have multiple benefits. So if we can help patients to achieve and maintain a healthy lifestyle as cancer survivors, we will definitely lower the rates of cancer recurrence. And you saw some of the figures that Carole quoted here. They're quite remarkable. We will lower their chance of getting a second primary cancer, because as we saw and we know, many of our cancers are related to lifestyle issues. So if we can help our patients to achieve and maintain a healthy lifestyle, not only we will lower the rate of recurrence, but lower the chance of a second primary cancer. We will help them to have better mental health. We will lower their cardiovascular morbidity and mortality. We will improve cancer fatigue. We'll improve cognition with less cancer fog. We will give them improved bone and joint health and overall an improved quality of life. And these have all been demonstrated in many trials. The effect specifically of physical exercise. There was a very good review by Lugo et al. That was published in Complementary Therapies in 2019. And I wanted to summarize from them the specific impact of physical exercise. There's strong evidence that regular, moderate intensity physical exercise leads to definitely lower rates of breast cancer and colorectal cancer in the first place, so prevention of those two, and lower rates of a recurrence of cancer in survivors. And that's been shown in breast cancer survivors, colorectal cancer survivors, and prostate cancer survivors. There's lower cancer-related mortality rates in breast cancer survivors, colorectal cancer survivors, and prostate cancer survivors, all from moderate intensity physical exercise. There is, of course, lower cardiovascular morbidity and mortality that's been shown to improve mental health. Physical exercise improves cancer fatigue. It improves cognition. It improves quality of life. So yes, healthy lifestyle overall can impact all of these, but specifically there's been hard data that physical exercise is one of the key things to improve in all of these areas. And as Carole has mentioned, the Clinical Oncology Society of Australia now recommends that all cancer survivors should be prescribed an exercise regimen. We should have it on our prescription pads. I wish we could. But the exercise regimen that is currently being recommended, again, as Carole said, was 150 minutes of moderate exercise a week. And when they talk about moderate exercise, they talk about jogging. They talk about walking. They talk about swimming. They talk about cycling. And of course, we can extend that to things like dancing, if you want to go dancing 30 minutes at a time, 5 times a week, but moderate exercise weekly. And add to that 2 to 3 resistance exercise sessions each week. They also recommend that cancer survivors should be prescribed healthy diets, high fiber, low fat, low red meat intake with 5 vegetables and 2 fruit daily. It's not a surprise to any of us. These are the sort of diets we've been prescribing for cardiovascular health. They recommend that they should be prescribed that they stop smoking, that they should achieve and maintain a healthy weight, and they should reduce alcohol consumption. Now, this is a big area that we don't know. So we know that physical exercise and healthy lifestyle has an impact on many of these indicators. What we don't know is how do we support patients to implement and maintain a healthy lifestyle after cancer treatment? So we actually don't know the answer to this question. This is called pragmatic research. Great, we've got the trials in, we've got the meta-analyses done, we've got the systematic reviews done, but how do you do this on the ground? So at the moment at UNSW, I'm working in a team that's conducting what's called a realist systematic review to look for evidence of effectiveness of interventions that would be implementable in Australian general practice. And when we say a realist review, that's exactly what we mean. We're not looking for evidence that physical activity works. We're looking for evidence of programs that implemented physical activity support interventions and actually worked and helped patients to maintain physical exercise interventions. So we've got some initial ideas on that, and some of the types of interventions that have been shown. And so the team is from UNSW, Griffith University and University Tasmania. And as I said, this is the title of it, a realist systematic review to look for evidence of interventions that effectively support healthy lifestyle changes that would be implementable in general practice. And we're specifically looking at physical activity. So there are several possibilities of interventions that have been used in Australia and overseas that have some evidence of effectiveness. In some places, it works to refer people for gym membership. Now, we know that that will only work in people that are able to afford gym membership. There's been some evidence that referring people for individual personal training with assessment of fitness and individualized planning of exercise. And again, that depends on what model and how expensive that's going to be. We've seen some evidence that referring for group classes, again, has some impact, but again, are group classes available? There's some evidence around motivational interviewing with ongoing counselling. There's certainly evidence about referring to exercise physiologists, and there's certainly some evidence about referral to dietitian. But what is going to work in Australia? We don't really know, and we do need input from general practitioners as to what's happening. We have a academic GP registrar that's going to be doing some interviews with cancer survivors and GPs around what they think would be implementable and practical within the Medicare system in Australia. But the one thing that I want to put out here in this particular meeting, and this has been already shadowed, that might be implementable in general practice settings with the Medicare funding is the use of GP management plans with team care arrangements. Now, I think all of us are pretty familiar with using this for some of our patients with chronic illnesses, particularly diabetes, but other chronic illnesses. But I want to put out there that I think we should be using GP management plans with team care arrangements for our cancer survivors. Remember that our oncology centres cannot refer patients to community-based allied health professionals on a Medicare subsidised plan. But as GPs, we can. We can give patients access to skilled allied health professionals that can really support them and design a physical exercise program for them. And remember, the cancer is actually a chronic condition. It requires ongoing surveillance, ongoing treatment and management of side effects of their treatment, and ongoing management of their other risk factors. So it is a chronic condition. And remember, we do have exercise physiologists in the community, and they are ideally placed to help our patients to choose an exercise program, to design a home-based exercise program, to counsel our patients on how to do strength resistance training with either a membership to the gym or with using TheraBands at home or with using equipment at home. They're very flexible. They know how to design and help patients to plan a home exercise program. And of course, with a team care arrangement, we can get 5 visits to an allied health professional. And so we may even be able to include 1 or 2 visits to the dietitian to help with healthy eating plan. So, as I said, I am not working full-time in general practice. I don't have a long history of working in general practice in Australia, as many of our participants do. But I think this is something at GPs we should really consider using this existing arrangement within Medicare to support our cancer survivors. They will get referral to our very experienced allied health professionals. They will do it on a Medicare subsidized plan. And if the patients want to join a gym, or they can do that as well. But that this would be a very good way of prescribing a healthy lifestyle for our patients. So as I said, I put that as a what we don't know, because I think we need to do a lot of work on this one. But I feel it's worth talking amongst ourselves as general practitioners as to the potential of using something like the management plans with team care arrangements to get patients access to allied health professionals that will enable them and design interventions for them so they can do their own home exercise programs. I think that is my last slide. I think I'm going to finish there. And at this stage, I think I need to stop sharing.
Lovely,
So,
thank you.
Thank you.
Yeah, that's
Thank you, Rebecca.
perfect. Thank you, Dr. Uebel, for your amazing insight into GP involvement in not only prevention but management of cancer. Are there any questions for Dr. Uebel? I have one, if there's none in the on screen. Do you feel that it's a necessity or appropriate for a GP to check back in with the treatment team before prescribing an exercise, advising on exercise, or referring on to an EP?
Look, if the GPs are going to be part of a cancer sharing, a shared care arrangement, ideally they should be getting a referral from the oncology centre. And certainly in one of the trials that we're doing, the so-called triage tool, one of the things we're trying to pilot there is a referral form with comments about lifestyle advice. And as I say, the Clinical Oncology Society of Australia is actually recommending exercise for all cancer survivors. Now, yes, of course, we need to communicate with our oncology centres, but I think we should, our approach should be that all of our cancer survivors could potentially benefit from an exercise program as recommended by the clinical oncology. And we should be working with our oncology centres and asking if there is any reason that people shouldn't be prescribed exercise. But I don't know whether Carole wants to have a comment about that, where there would be circumstances where they shouldn't be prescribed physical exercise.
I'm trying to think. I mean, almost everyone, please, 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 please prescribe exercise. And as Kerry said, if you've got the we don't have the access to those the GP management plans, so I tell my patients to go and do stuff, and they, especially in the public system, they can't afford it. I guess the only time, if you wanted to just check in, maybe sometimes if someone's got a bone metastases in sort of a critical site, so if it's in a femur or in a back, but I think you'd know that anyway. So with the exception of what looks like a critical site bony met, I can see no reason why not to refer to exercise. And we've got a couple of people around that we use who do really gentle exercise. They literally help people get out more effectively from a chair. And for the more frail amongst us, not amongst us, that sounded rude, then that's what they need. So yeah, we would love you to refer.
Yeah, and I mean, as far as I understand it, at this stage where we're looking at shared care between GPs and oncologists, you wouldn't be referring someone with stage 4 cancer with a bone met for the GP to be involved in surveillance or the cancer care.
The only ones perhaps might be some of like the prostate cancers with really good prognoses, or people with nasty poor prognosis cancers who we need to see often, we're really holding on to still, because things are quite quickly changing. But some of our metastatic prostate cancer patients live for 5-7 years. So in that situation, and some of our metastatic breast cancer patients with bony mets, we could consider too, as long as they're all stable, because they live for many, many years as well.
Right.
Okay, wonderful. Thanks to both of you for that response. Our next presentation is from Dr. Lynn. Dr. Lynn is a haematologist specialist at St. George Hospital. Dr. Lynn specialises in all areas of lymphoma, including bone marrow transplant. She also actively engages on the EBIQ Lymphoma Committee to further improve ongoing patient care. Dr. Lynn will speak to you tonight on the management of Mgus. Thank you, Dr. Lynn. Dr. Lynn, are you online at the moment?
Oh, hi. Sorry. Yes, it's LIU, but that's okay.
Oh my goodness, I'm so sorry.
Okay,
We have a big typo there. I do apologize profusely. I'm so sorry.
No, that's okay. I'm trying to access my sharing capabilities. Hold on.
Oh, okay. Would you like me to hand over to our final presenter, or are you okay?
Maybe hand over to the final presenter, and I'll try to sort out my unlocking system. Yeah.
Okay, I might get Lauren to give you a hand. Sorry to put you on the spot, Mark, but are you online and are you happy to give an overview? Oh, wonderful. Thank you so much. Thank you so much for jumping in like that. Now, Dr. Mark Topin is a GP and a clinical editor in the Southeastern Sydney Health Pathways team. He will just provide a brief demonstration on health pathways. Thank you so much, Mark.
Thank you. Okay, I'll share my screen. Can you see that?
Yes, I can. Thank you.
Okay, great. Yes, so thank you, Rebecca. So as you mentioned, yes, my name is Mark. I'm a GP. I work in the city, and I also work as a clinical editor for the Southeastern Sydney Health Pathways. So my role is to develop new pathways in conjunction with local specialists, and I also head up the reviews team. So each 3 years, all of the pathways need to be reviewed for accuracy and updates. And so I have a team sort of working under me, and I sort of oversee that. So I'm going to talk with you, just about the 2 local health pathways teams that sort of work quite closely together. So that's the Southeastern Sydney as well as the Sydney Local Health District. So hope all of our GPs online are all aware of the health pathways organisation. If you are not aware of the Health Pathways organisation, this is a website and also a QR code that you can scan now, and that will lead you directly to the homepage. So Southeastern Sydney covers the Southeastern Sydney region, encompassing Prince of Wales, St George, Sutherland, St Vincent's and the Sydney Children's Hospital, whereas the Sydney Health Pathways covers the Central Sydney region, encompassing RPA, Concord, Balmain, and also part of Canterbury Hospital as well. So you do need a username and a password, and you can request that from the homepage from either the Sydney or the Southeastern Sydney Health Pathways page. And now, thankfully, those passwords are now shared. So if you don't have a code, please log on and then contact our team, and we'll share the password with you. So just in terms of reminding about how to use the actual interface. So there's a really good search button, search tab, where you can type in either a drug name, you can type in a condition, and then it will come up sort of in the middle part, number 2, and just choose the relevant pathway. So obviously the most recent ones that we're constantly having updated are all of our COVID pages, and they're constantly be sort of updated every couple of weeks. There's a lot of new information that's out there. And then on the screenshot sort of on the furthest part on the right of the screen, just how you can actually search. So for example, if we do want to know about antiviral medications that we can use for our patients that have got COVID, typing it in, and then some of the pathways are they can unfortunately be quite long and not that easy to find some of the information. You can just do Control F. Firstly, expand all on the right. You need to make sure that you expand all. That expands all of the drop-down boxes. Then Control F and type in what you find. And then all of the highlighted areas will come up so they can be easy to find. Yeah, so key point is always just remember to hit expand all, or else it will only search for things that are not present within the drop-down boxes. So in terms of the relevant pathways, regarding cancer management, so the Southeastern Sydney Health Pathways team was created a bit later than the Sydney one. So we are, we're playing a little bit of catch up. So in terms of what is currently live, we've got Mgus, Acute Oncology Assessment, Oncology Advice and Advanced Care Planning. However, as due to one of an ongoing shared health priority within health pathways, as well as key stakeholders from all of the tertiary hospitals, is that cancer care and management is a big priority. So we do have lots more still in development. The Sydney Health Pathways has actually got a whole lot more live pages. And so certainly even if you are working outside of the Sydney region, or if your patient resides outside of the Sydney region, I frequently am logging on to different health pathways regions, trying to just get some advice if my current one doesn't actually have a live page yet. So we can see that the Sydney Health Pathways region has got a lot more active cancer pathways that have been developed. So if any of these are particularly interest of you and you've got patients with this, I really encourage you to log on and have a look at the most up-to-date advice that comes from us as GP writers, but everything is run by the local specialists, so we know that it's all up to date. So just another newly developed pathway that we've put in place is called GP colleague referrals. And so that if you or if somebody that you know are happy to take referrals from your GP colleagues on any of these conditions, please get in touch and we'll happily add you to our general practice colleague referral pathway. So this is currently only for Southeastern Sydney Health Pathways. So the current areas for current clinical areas for nomination is if you have an interest in Aboriginal health, aviation health, contraception, focused psychological strategies, performing iron infusions, medical termination of pregnancy, residential aged care, skin cancer checks, skin cancer excision, and transgender health. We would really love to hear from you. And if you would like to be put on to our website for all GPs within the region to be able to access, then that would be great. Also, similarly, if you have a patient who is requesting one of these things and you're not comfortable and you don't necessarily want to send them to a specialist, then please jump on and have a look at our general practice colleague referral pathways, and there may be someone close by who you may be able to get that help for your patient with. So please contact Sue Baker, sue.baker@health.newsouthwales.gov.au. Otherwise, you can log on to the general practice colleague referrals pathway, and then there is the feedback icon button, which you can see at the bottom right, which is that blue circle with the white sort of speech bubble thing in it. And you can please give feedback to any of the pathways that exist. Oh, okay, so there we go. So as part of, I mentioned as one of my roles is that I'm the clinical lead for reviews. And so what we really want to do is hear from you as users of these pathways. So we always want to hear from our users about if they have any difficulties or any questions or suggestions about the pathways. So the current set of pathways that are currently under review are the diabetes suite, cardiology, rheumatology, and immunology, infectious diseases, ophthalmology, pregnancy, and aged care. Aged care separately is being developed collaboratively in the future with Health Pathways Sydney. That hasn't started yet. So if you have any, I guess, interest or information, or if you've used some of these pathways recently and you've thought, oh, you know what, there's something that's not quite right, or there's something I don't understand, or something that I might suggest that could be added, if you've got that area of knowledge, we always want to hear from you. So as these are the areas that are currently under review, I really would encourage people just to log on to any of these and have a quick look, and please give us that feedback, and we will always respond as quickly as we can. So the contact details, so for the Southeastern Sydney, Anna McGlynn is the program manager, the reviews manager, Robin Hamblin, and the project officer is Sue Baker. And for Sydney, it's Paul, Tammy, and Cameron, who are all of your contact details. However, you don't need to remember any of those people. If you just want to give feedback, find a pathway you want to give feedback on, click that feedback button. Even if you can't find the right pathway, just give feedback. It comes to a central place and it always gets seen by our project officers and can be passed on to the relevant clinical editor for them to have a look at. All right, I will stop sharing. Thank you for your time. Was there any questions that anybody particularly had?
Any questions for Mark on health pathways? No, not at this stage. Well, you can always reach out to either team.
Please just get in contact online.
Okay, thank you so much, Mark, for jumping in and presenting on health pathways. Great referral service. And I would like to now reintroduce Dr. Liu. I'm very sorry for the hiccup before. Dr. Liu is going to be presenting on Mgus.
Yes, sorry about that. Yeah, I'm having some trouble with my computer. So I'm presenting on plasma cell disorders. I'm one of the hematologists at St. George Hospital. I do lymphomas, but essentially we cover all hematology. We can go to the next slide, thank you. I sort of want to cover what the different plasma cell disorders are today and what the diagnostic criteria are and what tests to order, maybe a little bit about how to interpret them and the follow-up, and I guess from the GP's perspective, what to look out for and how to be involved. I think myeloma is one of the more common conditions that we see in clinic, mostly because Mgus is actually fairly common, but also myeloma has now become almost like a chronic condition with how many lines of treatments we have. I think previously, if people get up to 5 years, sometimes that's actually quite good. However, now we have so many lines of treatment. Now they're sort of more like a chronic disease patient. Yeah, we can go to the next slide. What are the different plasma cell disorders? So the IMWG is the International Myeloma Working Group, and Mgus is the monoclonal gammopathy of unknown significance. And then it goes on to being smoldering myeloma, which is still, it's sort of halfway between Mgus and multiple myeloma, where there are certain criteria that it's met where it's no longer Mgus, but they don't have the end organ damage of multiple myeloma. So we still don't really treat them, but they're obviously a little bit higher risk of progression. Then there's plasmacytomas, where patients present with just a plasmacytoma rather than bone marrow involvement, and plasmacytomas or plasma or lytic lesions, and that's treated slightly differently. And then there's plasma cell leukemias, which is really a very aggressive form of multiple myeloma where they have circulating plasma cells, but I'll go through a little bit about that. Yeah, next page. So it's a very busy slide, but this is essentially the diagnostic criteria for IMWG. And if you're interested, that's a website that I've put in the at the top, and essentially that tells you exactly how we differentiate all the different plasma cell disorders. So essentially, to be Mgus, you have to have less than 30 grams per liter of a non-IgM paraprotein. Clonal bone marrow plasma cells have to be less than 10%, and also absence of end organ damage. So that's what the CRAB symptoms are. So hypercalcemia, renal insufficiency, anemia, and bone lesions, or amyloidosis, which I will touch on a little bit at the end. That can be attributed to a plasma cell proliferative disorder. So essentially, they have paraproteins, which is less than 30 grams. They can't have too many plasma cells in their bone marrow, and they can't have any end organ damage. And essentially, smoldering myeloma, as I said, is sort of somewhere in between, where you have more than 30 grams of paraprotein, but they don't actually meet any of the criteria for end organ damage, or they have 10 to 60% of plasma cells in their bone marrow. And then there's obviously multiple myeloma, which we'll go through a little bit in more detail. I won't go through plasmacytomas in too much detail, but essentially they have a single plasmacytoma without any other organ involvement or any bone marrow involvement. And then there's plasma cell leukemia, which essentially means they've got circulating plasma cells in their blood, and it has to be more than either 2 times 10 to the power of 9 per liter or more than 20%. Next slide. So again, this is all from the website, so I won't go into too much detail, but there are the first couple of points are essentially about the CRAB criteria and what we look for specifically with hypercalcemia. There are definitely cutoffs, But, you know, if they've got a little bit of hypocalcemia of 2.6 and then they've, you know, got other contributing, potential contributing causes like hyperparathyroidism, or they've got renal impairment that may be a cause for it, then potentially we might need to exclude those before we can call them multiple myeloma. And the slightly newer additions to the IMWG criteria that's been added in the last couple of years now is that if they've got no CRAB features, but their plasma cell involvement in the bone marrow is more than 60%, or their light chain involvement of the involved to non-involved light chain is more than 100, then it's still considered multiple myeloma. And also MRI, if they pick up a lesion that's more than 5 millimeters, then more than one lesion, then that's also considered multiple myeloma. Next slide. So how common is Mgus? So Mgus is quite common. So this is from the 2006 NEGIM article, but essentially it's in 5% of patients over 70, and in about 7.5% of patients over, of the population over 85. And they have about a 1% per year chance of progression. But I think that number is sort of over all the people that have Mgus. Obviously, some people you will recognize fairly early on that they will probably progress a little bit faster than others. You know, do we screen everyone for Mgus? We don't generally tend to, because because it's so common and it, you know, we don't really change our overall management. It's just more monitoring. We don't necessarily screen for them, but we do see a lot of people coming through, you know, who are asymptomatic, who are picked up from rheumatology, renal, or neuro, because they can present with so many different presentations. Next slide. So again, this is the IMWG recommendation. It's on the website. So it's a very busy slide, but essentially the recommendation for testing for Mgus is to go through a history examination. People often ask what to look out for in in terms of symptoms. Unfortunately, with multiple myeloma, there's really not much to look out for to detect progression of the condition from Mgus to myeloma. So people generally present with very sort of non-specific symptoms, like they'll be very tired or just generally feeling unwell. They might have lost a bit of weight. So usually it's really picked up through blood tests, unless they have like a pathological fracture, which obviously will just present with very focal pain. So generally we just ask people to sort of monitor themselves if they feel very unwell for a very extended period of time with no reasons, and potentially get a blood test and see if there's any of those CRAB features that we can look for. Routine blood tests, so full blood count, UECs, CMP to look for calcium, renal function, and anemia. And then what we look for in terms of the proteins, we do the serum EPG, IEPG, and also the serum free light chain. So the light chain is essentially just part of the actual antibody, and we know that some people don't actually have very high paraprotein, but they actually present with light chain disease. Those people sometimes present a little bit more with renal renal impairment rather than anemia. But in general, like, we do all three of them, because you need to monitor all three, both the paraprotein and the light chains, to look for to essentially monitor their either for progression or for response to treatment. And nephelometry quantification, essentially that's we quantify the immunoglobulin levels based on the IEPG, and that's just the method of how they do it. But usually if you order the IEPG, it automatically comes with the quantification and the identification of the paraprotein. So if you just order the EPG, it might show you that you've got an abnormal band, but then you need to order the IEPG to then identify it and quantify it. And the routine 24-hour urine collection, usually we do protein, electrophoresis, immunofixation, as well as Bence-Jones protein and albumin, just to quantify whether they've got nephrotic range proteinuria or not, or whether they do have any Bence-Jones at all. Bone marrow testing. So do we do this on every patient with Mgus? We don't. I think it's a little bit down to sometimes physician experience, and also how comfortable they are with the patient that they see on the day. So if someone has a very low paraprotein, normal bloods, normal renal function, normal electrolytes, and otherwise fairly asymptomatic, then generally I don't tend to marrow them, because it's very unlikely to change my immediate management. But if they present with a slightly higher paraprotein, then I do tend to marrow them, just to make sure that they don't have the marrow definition for multiple myeloma, which will require treatment. And I think if you suspect that they're going to progress relatively soon, it's also not a bad idea just to have that already, because I guess the percentage of plasma cells in the marrow doesn't really affect when you start treatment. So if you think they're going to progress soon, then you might as well just have the marrow, because what you want is also to know the cytogenetics and the FISH, which is to look for very specific mutations of the plasma cells. These are not important for diagnosis, and more so important for prognostication. So again, we don't really need them at the moment to start treatment, but we do not like to know, because it helps us to tell the patients and discuss, I guess, their prognosis. But we don't usually use them to guide, I guess, how often we monitor them. In terms of imaging, now I think in the last couple of years, they have approved CT skeletal surveys rather than X-ray skeletal surveys for looking for lytic lesions. And essentially, it's a very low dose CT that mainly just looks at the bones. And it's usually fairly quick to get one of those. And generally, sometimes it is a little bit harder to sort of interpret, but I'll talk about that later. PET scans and MRIs are obviously more sensitive, but the PET scan is not currently reimbursed by PBS, so they do have to pay out of pocket. So unless we need to look very specifically for active lesions, we don't tend to order them routinely, but they can be done. Again, MRIs we do if we think they have specifically spinal lesions, to look for spinal compressions, but also sometimes we do them if we think they do have a plasmacytoma that's not identified or easily identified on a CT. I think we can go to the next page. Thank you. So how to interpret some of the tests. So free light chains, we actually get caught up a lot about these, because they do tend to sometimes be elevated even in normal people, and sometimes it'll come out with one of them, either the kappa or lambda will be slightly elevated, or both of them are elevated, and it's a little bit hard to know whether it's pathological or not. If it's very mildly elevated, but the ratio is normal, then we tend to just monitor them. And but if it's sort of both elevated, so today I saw someone who had a kappa of 200 and a lambda of 180, but the ratio is actually normal. So normal, I think, for kappa is about 20 or 30. So even though both of them are elevated, the ratio is normal. So overall, we still think that it's probably normal, because the light chains, essentially what we're looking for is clonality. So you want to see a difference in the kappa and lambda, because if both are elevated, it's probably inflammation rather than disease. In terms of bony lesions, so I think sometimes it needs to be interpreted with caution, especially when the lesions are very small. I think sometimes especially the very small lesions, they can be sometimes a little bit overinterpreted. So sometimes if they're very, very small lesions and the patient's asymptomatic, and I don't think they've progressed biochemically, I do send them for a PET scan, just so I know whether those lesions are active or not. And if they're not active, then there's probably less likely to be myeloma. So then we just continue watching them. In terms of the EPG, IEPG, sometimes you can get high and low gamma globulins on the EPG because that's just looking at all the proteins without identifying a paraprotein on the IEPG. And I think that's why we need to sort of do them together. Next page. So what we do treat are myeloma, the multiple myelomas, plasmacytomas, and the plasma cell leukemias. The Mguses and the smoldering myelomas, we tend to just watch them. Next page. So in terms of patients that we just watch and wait, what we do is really just clinical assessment, do the EPG, IPG, and serum free light chains. How frequently we see them depend a little bit on how high risk we think they are to likely progress. So someone who's been very stable with 5 grams per liter of paraprotein for many, many years, we might see them maybe once a year just to make sure everything's stable. It's really hard to know exactly when people will progress, because essentially what we think is when they're Mgus, they probably have one of the mutations that we know of. And then when they get a second hit mutation, they probably become multiple myeloma. And those are really hard to pick up. And sometimes we will see people who come in for a routine blood test, but their blood tests show that they've transformed to myeloma, which is a little bit unexpected, but I think it's hard to sort of pick those patients sometimes. So again, we just check their routine blood tests, and again, depending on their symptoms, sometimes we might do yearly or sometimes less frequent skeletal surveys, depending on how stable they are. Next page. And in terms of active treatment for patients, so nowadays there's just quite a lot, but if they're under 70 or they're around 70 and fit and well, they go through induction chemotherapy plus an autologous stem cell transplant. And despite all the new treatments nowadays, I think that's still the standard of care in I think most countries in the world. And then after that, we do have, for those who are not eligible or those who have relapsed, we just go on to other lines of chemotherapy and then radiotherapy if they have symptomatic lesions, and then just symptom management and bone health, and we do give almost all our patients who are on active treatment are also on regular Zymeta if they have decent renal function. Next slide. So what is available at the moment for treatment of myeloma? There's a lot that's been approved now. So Cyborg-Dex is what we used to use as induction, but now I think we mostly use VRD, which is lenalidomide, bortezomib, and dexamethasone. But as you can see, there's a lot of other treatments we have. So carfilzomib, pomalidomide, daratumumab, elotuzumab, which only came on PBS this year. Thalidomide is a slightly older drug that we still have available, but we don't use as often just because it has a lot of side effects, and we have sort of other drugs that are available. So we don't use it as much, but it is there. And we have quite a few clinical trials as well, including belantamab, which is a specific BCMA antagonist, and venetoclax is what we normally use for CLL and AML more often, but it's now being trialed in a very specific group of myeloma patients who have a mutation, because I think those patients do better on venetoclax. And we do have some trials for CAR T cells. It's not yet standard of care to give it, and I think the evidence is still fairly early at this stage, but I think people have started asking us about it, so they might also talk to you guys about it. And allotransplants we don't really do for patients with myeloma unless we have no other options, because it doesn't tend to work particularly well, and it obviously comes with a lot of morbidity. Next slide. So what we think potentially we can work together on with these patients. So during the monitoring stage, we don't see them particularly often, maybe every 3 months to a year, depending again on how likely we are to think that they will progress. And really just about managing their comorbidities. So all the other comorbidities are likely to be present, especially in the older population, because people with myeloma tend to be older. And vigilance about potential symptoms. Again, there's not a lot to look out for, but potentially atraumatic or minimally traumatic fractures, a sudden rise in creatinine without any reversibility or cause, a high calcium, again with no cause, and unexplained or worsening anemia. And patients on treatment, one of the biggest things with these patients is with the steroid use, because we give such high doses of steroids. So usually they're on, sometimes they're on 20 to 40 milligrams of dexamethasone on a weekly basis for potentially several months. Sometimes if they already have diabetes, it tends to make their diabetes a lot worse, or they develop steroid-induced diabetes. And reflux is another big symptom that goes with the steroids. Potential infections, so definitely shingles is one of them. So most of our patients are already on Valtrex prophylaxis as well as Bactrim prophylaxis for the, because they're on so much steroids, but definitely they can get other infections because of even if they haven't been on treatment, they might have secondary hypogammaglobulinemia, so they might need regular IVIG as well. And surveillance for other cancers, so skin cancers, bowel cancers. I think because these patients are now surviving for so long, sometimes 10 years or more, then they need to be surveyed for other cancers as all of the rest of the population. And pain. So a lot of these patients do have chronic pain, not necessarily because they've got ongoing fractures or lesions that are active, but I think a lot of these people tend to have chronic pain even if their lesions are no longer active, and sometimes we don't really know why, but they do sometimes just need a little bit of pain management. Next page. So in terms of the post-transplant setting, I think that's something I'm trying with Jeremy and I have been trying to work to develop a plan for the GPCanShare program in terms of trying to, I guess, have a more standardized way of managing post-transplant patients, because I think for us, I don't think we have as big of a survivorship program as the oncologists do, but one of the biggest things is the post-transplant vaccinations, and it's actually quite onerous. Essentially, they have to be revaccinated for everything, and it's really a almost 6 to 12 month process, which starts at 6 months post-transplant. And unfortunately, these are also not paid for by the government. Next page. So Jeremy has kindly put this together, and essentially, I think these are the just maybe generic prices, but it can be quite expensive for patients to go through all of the vaccinations. It's not all in one go, as you can see, it goes from 6 months to 24 months, but definitely there is a out-of-pocket costs, unfortunately, which we can't cover from the hospital perspective. Next page. And again, I think ongoing management of mostly the side effects from the steroids is very important for diabetes, hypertension, cholesterol. Osteoporosis, I guess we tend to manage those a little bit because they tend to continue on Zameta for a little bit of time after the transplant. But I think, one of the things that we're trying to see whether we can implement is really linked to allied health outside of the hospital, especially with dietitians, physios, and mental health support. So a lot of these patients have sort of been in very close contact and have been in hospital for their transplant a lot during that period of time, that initial 6 to maybe 9 months of time. And then they sort of suddenly disengage very suddenly from us. And I think some people do get a little bit of a separation anxiety when that happens. And I think sometimes there's a lot of anxiety with when this will come back. you know, how to deal with, you know, the loss of independence during that period of time, and definitely going through a malignancy. And now they've sort of gone through the transplant, but unfortunately, the transplant's not curative. It's still considered life-prolonging treatment, but it's not curative. So I think there's a lot of anxiety around that for a lot of the patients, and I completely understand that. But I think a lot of them may benefit from psychology support during that period of time. And sexual health and fertility. And I think earlier it was mentioned that obviously they have a very close relationship with GPs. And I think that's very important because they sometimes don't tell us these things in our very brief visits sometimes. But I think it's important to address those things. Some of it is related probably to maybe the treatment, or sometimes it's related to their mental health. And I think that has to be addressed. Because they are an older population, fertility is not usually an issue, but I think for younger patients, because now we are seeing patients that are a bit younger with myeloma, definitely fertility might have to address as well. Like, we tend to try and address that in our younger patients pre-treatment, especially if they're having a transplant. But I think, again, it would be good if we can all be involved in that discussion. Next page. Sorry, I think I'm very over time. Prognosis, so I'll just finish on this page, I think. So I tend to tell patients that myeloma is incurable, but it's very treatable. So once they've, so because we've got so many lines of treatment now, like I think even if they relapse relatively quickly after their, so how quickly they relapse after their transplant usually tells us how aggressive their disease is. And, you know, prognosis is very variable depending on patient factors. So how old they are, their comorbidities, how well they tolerated treatment, what other conditions they have, and disease factors. So some people just have very aggressive disease, and no matter what you throw at them, they will relapse very, very quickly. And then there are other people who have fairly, it's not indolent, but like fairly sort of slow progressing disease. So, you know, I've seen patients who have been transplanted over 10 years now that are just coming back with their myeloma that need to be retreated now. So there are people that have a very long sort of lag time between treatments. And I think the other difference between treatment now and treatment years ago is that after the transplant, before they're sort of on a off period where they're not on any treatment until they relapse and they're on treatment again. But now, because we've got approval now for lenalidomide as a maintenance treatment, everyone who have gone through a transplant essentially nowadays go on to lenalidomide maintenance. And essentially that's ongoing until they progress. So we still see them every 3 months when they go on to the maintenance part. But I think lenalidomide, it's not a benign treatment. Like, some older patients especially find it really hard to tolerate, and they do get a lot of symptoms from it. So I think, you know, we try to manage those along with palliative care, who are also very heavily involved in the myeloma patients. But I think there's a lot that we can address, I guess, as a team, because they will definitely see you guys a lot as well between all of these, just to address all their medical issues. But yeah, nowadays they're sort of surviving, you know, even if they relapse sometimes, you know, 5-10 years, and it's not unusual to, you know, go through multiple lines of treatment, but it gets increasingly difficult. But yeah, that's I did sort of wanted to touch on amyloid, but I think we're out of time, so I won't do that. Any questions?
Any questions at all for Dr. Liu?
Sorry, I'm very over time.
Oh, no, please don't apologize. If anyone does have any questions, if you just want to include them in your evaluation survey, and we'll pass them on.
Yeah.
thank you again for that really informative overview on myeloma and Mgus. That was really interesting. Thank you to everyone for attending and contributing to tonight's event.